Good morning. I will call to order the Yakima Board of Health agenda for April the 30th, 2025. And we are waiting. We'll move ahead here. We're waiting. We have one more person coming in to make our quorum for today. So is there any introductions to 20, Mr. Ivan?
No, no, it's not.
Here we are. A quorum. That's right.
Never, well, I'm sorry I was late. I got rear-ended, but I'm here.
She got.
That's
Oh,
all,
yeah.
it's got rear end.
Oh,
That's terrible.
So the clap was nice.
Again.
Well, thank you. We're glad you're here. And we have a review of submitted public written comments. Anything?
Good comments.
Okay, well, nobody's here in the audience either. We'll move right along. We'll move to the consent agenda. All items listed with an asterisk are considered routine by the health board and will be enacted by one motion. There will be no separate discussion of these items unless a board member requests, in which the event the item will be removed from the consent agenda and considered in a normal sequence on the agenda. Anyone on the board wish to remove an item from the consent agenda? Seeing no one, Mr. Ivan, would you read it, please?
It's March 26, 2025, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in March 2025 in the amount of $952,333.43.
I would entertain a motion.
Motion.
Second that motion.
We have a motion. I'll state what it is to approve the consent agenda as read. All of those in favor, please say aye. Aye. Any opposed? Motion passes. Thank you. We're just having a little fun this morning. Next on the agenda is our Yakima Health District Spotlight, strengthening overdose surveillance through partnerships. Lillian Bravo.
Good morning, everyone. So today we'll be talking about some of the work that's been taking place over the past year, specifically around, again, some data. But today we'll be talking specifically around opioid overdose data. So to remind everyone, we are still currently in the midst of the opioid overdose epidemic. That is a national problem just as much as it is here locally. But here locally, we know that that is something that we consistently hear about and want to address. However, one of the challenges remains that we have traditionally not had real-time data. Many traditional data sources take about 12 to 18 months to receive. And if you don't have a clear picture of what's going on, it makes it hard to be able to respond. So that's what we'll be covering today, is how we've been able to work together with our partners across the community to get more accurate data and have it be available across the relevant entities. The first and foremost, the most important part of this is what's called the Overdose Detection Mapping Application Program, or ODMAP, which Melissa will be actually letting us know more about.
I think most of us are familiar with this. We've talked about this a little bit in our previous Board of Health meetings. ODMAP started in 2016. It launched. It was started around on the East Coast by Washington and Baltimore area. They were looking at overdoses and looking at a way to make look at overdoses in real time. So they created this application software that has now branched out and gone nationwide, and it really got pushed out in 2016. We actually, as a county, looked at it in 2016, 2017. And it's really taken off over the last year and a half or so with the help of Safe Yakima Valley. So we're using Safe Yakima Valley has really pushed this out so that our law enforcement officers, our EMS, first responders, they put the data into, they can either put it in manually and it reports to this application, ODMAP, that will give us real-time data of overdoses as they're occurring or near real time. I think, is it later on that we talk about the partnerships and the funding?
Go here.
Okay. Sorry, kind of drew a blank there. So we look at the information real time and I lost my train of thought on this. Help me out.
Yeah, so one of the pieces, as Melissa mentioned, with Safe Yakima Valley being the one that primarily championed this work, the Yakima Health District was able to assist with the technical aspect, as Melissa mentioned. It's pretty difficult to have all the law enforcement agencies to have all their information in one place, which is the interface. And that's where the Yakima Health District was able to provide funding, the $20,000 to make that happen. So with that investment, we were able to actually bring all these data sources together into the system. And on the slide itself, what you can see is a snapshot of what the system can create. So as you can see, there's orange and yellow, orange being more dense areas of responses to overdoses. Unfortunately, a lot of this information we won't be able to share publicly outside of this image that is being provided. And that's again to ensure that there's privacy amongst the data that's being presented. However, everyone that is able to access it are the people that are inputting data, so law enforcement, first responders, hospitals, the health district. We're all able to look at that information in real time. It just wouldn't be able to be shared out into the community.
And so in Washington State, as I was mentioning, it's kind of branched out and gone nationwide. In Washington State, Yakima County is one of the first ones to actually use this with the majority or 99% of our first responders. So we are one of the few counties in Washington State that's actually getting near real time, because what we've noticed when we were trying to collect this data is that most of the data was, 12 to 18 months behind by the time we got it. So it wasn't giving us a real accurate picture of what was happening in our community in real time. So we're able to monitor spikes and trends in our overdoses using this, because it reports not only non-fatal, but also fatal overdoses.
And if I may, also, there's a tendency in data sometimes to have what can be described as selective bias. If you're only looking at the data for deaths, so you're only looking at the data for people who are admitted in the hospital, it doesn't show the full impact on the community, which is really exciting for us, because obviously the response rates for police and fire has been enormous here, and understanding that better allows us to understand where the problems lie.
Yeah, and there's two different ways you can manually put this information in, and what William was speaking about the funding that allowed first responders. Yakima Health District was able to help with those agencies that don't have the manpower to manually put these in, but their data is so important to this community that we were able to provide funding to allow for an interface so that there's no manpower. As soon as they respond to a call, that information automatically gets populated into the ODMAP system.
So as we wanted to make sure that we highlighted ODMAP first, because clearly that is a huge that was a huge effort to bring all those data sources together and to have it, as Melissa said, almost in real time. However, it is important to also look at the other traditional data sets and put all of that together. So moving forward, one of the things that the Yakima Health District will be doing is putting together a quarterly opioid overdose report. And it will include not only information from ODMAP, but also from EMS, again, looking at how many times first responders are going out to respond to these overdoses, but over a period of time. Information from hospitals, which is the hospitalizations within emergency departments. Also information from the coroner's office on the deaths, which includes demographic data. And then also looking at the behavioral insights from the questions that we ask at the vending machines, again, in Toppenish at the Yakima and in Yakima here in the OIC. So one thing that I will preface is that, as I mentioned, this information is not yet publicly available. So the information I'll be able to provide today is very limited. However, it is our plans later in the year to develop something that is publicly available. We just need a little bit more time to be able to parse out the different variables in a way that's appropriate to share with the public. But we recognize that it's not just important for the people directly responding to this epidemic, but also to make sure that this information can be consumed by the general public as well, because we're all living in this community. But overall, what the data is showing is that there, in the first quarter of 2025, that being January 1 through March 30th, there has been a decrease in overdose deaths and EMS responses in comparison to last year. So that's promising. Also from the vending machine data, you can see when we compare the 2023, 2024, and 2025, just to make sure. So far in 2025, the percent of people that are saying that they have access to naloxone has significantly increased. So that's promising news as well. Of course, this is information collected from people that are going to this vending machine, but I do want to say that it's a good positive factor in terms of, we know that there has been lots of initiatives taking place at the state level with the standing orders to allow the general public to carry naloxone. The State Department of Health has been working hard to distribute naloxone to different high-risk organizations, including our harm reduction program. And then most recently, first responders are getting access to that naloxone as well. So even though it's a snapshot from within our community, I do think it paints the picture of just the tireless work that's been going on across the entire community to increase naloxone access specifically. In the report, when we're able to share that back out, there will be more information in terms of the geographic spread, the demographic information of people impacted and the deaths. And again, even though it's not being able to be shared right now, we are going to be able to use that information to directly impact some of the program that we develop in the future. And so, of course, none of this would be possible without various partners coming together. We listed out all many different data sets, and each and every one of those partners is helpful in making this report and this information possible. There's various initiatives that are taking place with the opioid response specifically, and I'll let Melissa speak to the monthly overdose and quarterly fatality rates as well.
So the monthly overdose response meetings started last fall. They're now being run by, led by Yakima Health District, Andy, our local emergency response coordinator. Those meetings are more specifically for first responders, emergency rooms, firefighters, to kind of look at how we can combat current issues that are going on and responding immediately to the overdose spikes or trends high trends that we're seeing in our county. And then also the quarterly fatality reviews is a separate program similar to the child fatality review program that we have. It's going to look more at the overall lifespan of an individual, not just a child, but this one branches out to anyone who died from an overdose. And it looks at their life overall and looks at more of the upstream things that we can change to prevent the overdose from happening in the first place.
And then in addition to that, Melissa referenced earlier, there are things called the OD spike alert. So those are communication efforts that when there is an overdose spike in the community, that there's mass messaging that goes out to those that might be impacted by an overdose. So for example, letting the community know that something like that is happening will allow for more naloxone to be pushed out. And then also for people, for example, that go to the harm reduction site so that they can know, so they can take the precautions as well, knowing that perhaps there's just a bad batch of drugs or whatever it may be, but allowing us to actually take quick action to hopefully save some lives. In addition to that, there are things like community events, which some of the community coalitions do, which is Take Back Day. And that's more on the preventative side, just to make sure that people don't unintentionally get access to some of the prescription drugs, which is also an avenue to eventually have issues with overdoses as well. So to sum it up, while this is not a mandated service, of course, you've heard the word partnership many times. And in terms of increasing the effectiveness and efficiency, making sure that all this information is available is going to improve the efficiency of everyone's response. The problem is big, so the more information that we have, the more that we can focus our efforts, both for responding to overdoses right now, but also to responding to the prevention of the epidemic overall. Any questions?
Just one, we're seeing a trend nationally where the trend looks like it's going in the right direction for overdose deaths nationally. However, in Yakima County, we're not seeing that same trend. We're either not seeing a leveling off and yet we're still seeing high numbers. Any ideas for the board for how we might make an impact to see the same trend locally that we're seeing nationally?
Yes, I think honestly, we need more information to be able to answer some of those questions. So I think we're going in the right direction to be able to get a better picture of what is actually happening right now. So it's too soon at this point. That's why we're starting these efforts.
Got two questions. So you did state for Q1 of 2025, we are seeing a decrease here in Yakima County. Is it slight or significant, or I mean, how much of a decrease is a decrease?
The decrease is, I'm pausing because our epidemiologist was very strict on what the terms I can use. But it is, I would say it's significant. It is a significant decrease. And hopefully we can work a little bit faster to share those numbers publicly too.
Very good. And one question is, you talked about the various, partners in the county that you're working with, like, for example, the emergency departments. I know at a time there was a little bit of a struggle getting that, rapid communication. Is that improved?
Melissa.
Yeah, I mean, I would say absolutely. That's
Okay.
something that we work on every day, not just in overdose, but even our communicable diseases. We've established a really great relationship with infection prevention and emergency room physicians. Part of that would be with our provider resource page, our provider monthly meetings that we do, provider alerts that we send out. So we've really expanded our partnerships with them. But One of the things the emergency rooms do is they've been on board with the OD map, so they're also putting in the data in the OD.
Excellent, okay.
And if I could just add, Commissioner, one of the things that we see is hardworking people in different areas of focus in our county doing great work, but it's overwhelming to try to create a systems approach. And so we have been trying to support all of these hardworking agencies at coming up with a better, less complex way of communicating, which has worked out well. And it's one of those things behind the scenes that costs money and time, and that's often why it doesn't happen. But it also, in fairness, it's hard to keep pace with an epidemic like this. So that's one of the things I guess I want to share is that while we remain optimistic because these collective partnership efforts are working, it's not stopping the use of these dramatic drug problems that we have. And in fact, to your point, Dr. Atterbury, about it, there's trends that say that with poverty comes different drugs. And so we're a rural community, and so we're actually ramping up around concerns around meth labs. And so we've got a lot of rural areas of the county, a lot of people who own property that they go to infrequently, and those are perfect places for people to make drugs. And so we're starting that process now in preparation. Unfortunately, when you have a change in the economy, people's drug of choice changes as well. So we're trying to keep pace with that.
Any other questions?
Just one of the things I really appreciate about the OD map system is that we're just not documenting the overdose deaths, but we're tracking overdoses, period. Which, and I know when Alicia brought this to us, which was, you know, the idea that really demonstrate the full impact, because even if somebody doesn't die, there's still an impact.
And one of the things actually that we're seeing too is the impact on the day-to-day work of our partners. It's a great deal of stress and of investment to roll out to these locations. And that's one of the things that Melissa's working on too, is how to provide some support to our first responders who are really stressed about the situation. It's really hard when you've got multiple calls happening all the time. So we're talking about ways to support them. And the other is that I just wanted to share with the board that we'd like to continue to make the financial investment in this program as well. So again, it's a partnership, but we recognize that there's limited resources for some of these things. So we'd like to continue to support that next year as well.
A comment, can you go back to the first paragraph?
Thank you, Maria.
So if you look at, let's say, one of the colors, you know, whether it's either Toppenish or Yakima, the Yakima in particular, when you make an intervention at specific time, so the naloxone rollout didn't happen a couple of weeks, probably happened over many months, but compared to the data we have year after year, you can call that the end of the before. So there's a problem, in this case, overdose. And when you implement something like naloxone, of course, a lot of other things have happened at the same time. What we should now see is a decrease. And what we see now is actually a leveling of the slope. And then if we go another year or two, if it starts to decrease, then it suggests that those interventions that happened pretty much over the last 2 years maybe have made a difference. And we can't really filter out single ones because multiple things happen at the same time. In the hospital, we can do it because, let's say we have too many IV line infections and we implement that program, we do it all at once across the hospital. And then you can see the before and after differences. So hopefully that decrease in the rate of rise will now turn into a decrease on next year's data. And then we know where we got on top of the stuff. If it doesn't, if it keeps going up, we got problems.
Thank you, Dr. Bark. Any other questions or comments? Hearing none, we'll move on to our agency reports. The first is our Executive Director, Andre Prescott.
Thank you. Good morning to the board and to the public who's watching. I'm grateful to be here with you. First, I want to recognize one of our long serving staff. He doesn't often like attention, but Ryan Ibach is up on 26 years of service at the Yakima Health District. So I'm grateful for his service. And again, he doesn't like attention, but that's why I like to give it to him. I started out as an environmental health specialist here. I think we figured out one day it's probably about 6,000 restaurant inspections. So needless to say, he has a lot of experience. And he comes to work every day with the same level of commitment and optimism and quiet, hard work that is representative of what we do. So grateful to you, Ryan.
Thank you. And I started out when I was in first grade.
It's not lost on me that we're of the same age by a few years, but I look like his dad, so that bothers me a lot. So be it. I guess it comes with the job. So thank you, Ryan.
Ask him what he was driving or what he was listening.
Oh, yes. What were you listening to?
We all know.
We all know.
Yes, Living La Vida Loca was the number one
He came
song.
rolling in here in the parking lot on his first day.
1997, yeah, probably didn't have air conditioning back then. Now it does. So we're grateful for that. One of the things we always talk about here is whether it's your first day of service or your 30th year of service, as long as you show up with a commitment to our community, then that means you've earned your paycheck. So grateful to that, but it's a wonderful legacy, again, to have people who come to work committed to the job even after you. I wanted to start with a recognition of someone that we've lost in our profession. Mary Selecki passed away early this month. For those who are not familiar with Mary, Mary was our longest serving Secretary of Health in recent years. She served for 15 years through 3 different governors. So she was here when I first came. And then we've had 3, well, we'll be on 3 Secretaries of Health now since she left. But she came from Northeast Tri-County. So she was a local health director. A lot of times secretaries of health or commissioners, as they're known in other states, are political appointments. And often those people don't have any understanding or recognition for local public health service. Mary really lived that work. She was a fierce advocate for local communities. She came from a small rural community, so she understood the complexities that we had here. And I share this with you because she was very committed to doing the right thing. So when I first came to this state, she pulled me aside and said, I've been checking on you. I want to make sure that you're going to do a good job. She called the Commissioner of Health in Tennessee to check on whether I was going to take care of Yakima and whether I was going to be committed to Yakima. But that's the kind of level of fierce advocacy that she had for doing right by local. And I share that with you because it wasn't just public health that she loved, but it was service to local people. And she was very helpful and instrumental to me personally when we were trying to find more funding for this community. Again, Yakima is the kind of community that can get overlooked on the west side, and she understood that we wanted service to be exemplary here. And I just wanted to share with you that her legacy has continued because of the investment she made for us in Yakima at the Yakima Health District. So thank you. And I thank you for allowing me to honor her. One of the things that we worked on as part of her tenure was the foundational public health services system that we now enjoy. Again, that was the idea that the legislature had not invested in local communities for decades, the way we felt it should. And so now, as part of our money that we received from the state, we received this foundational public health services investment. We've been waiting anxiously to hear about the governor's budget because that impacts this amount of money. So we have found that out now. If I'm not mistaken, it's passed both houses of the legislature, but it's waiting for the governor's signature. There has been a reduction in that funding, but not as dramatically as it could be. It looks to be 44 million reduction over the biennium. I want to make sure I say it correctly, but it's going to be backfilled hopefully with vape tax money to the tune of 20 million. So the total amount currently that we would lose would be 24 million over 2 years, which is 12 million a year. I know that's a lot of math and a lot of optimism that you're going to generate taxes. So the full amount would be 12 million each year, potentially 22 million each year. That is a large amount of money, but in terms of the amount of money that's been invested in our local community and statewide, we're still in a good place. So people were advocating on behalf of public service, but also local investment. So I'm grateful for that. I wanted to share that with you because we're working statewide and making certain through a concurrence process that we understand how that reduction will play out. If it were to be a straight across the board reduction here, we could be looking at just under $300,000 loss up to just over $500,000 loss. That's something that we can manage here. So I just wanted to share with you in earnest that I think we're still in a good place financially in terms of the budget. We haven't had a change in any of our normal monies that we receive from the state. That doesn't mean it won't change. The state has been reducing dramatically. They're going through layoffs. They're going through reductions in departments. They're going through consolidations of departments. We at the local level have not had to do that. And so I count myself lucky that we're not dealing with a fiscal crisis, but I did want to be very upfront with you about finances. The only caveat is we don't know what's going to happen with the federal budget. And of course, that comes in the summer with more information, and certainly the new budget will begin for the federal government October 1. So we'll hear more. But I wanted to give you a brief financial overview because it does happen very quickly in the state. We have to have a budget. That's it for me on that issue, unless members of the board have questions. Thank you. We're also doing some active planning. You'll hear more from Ryan, but we're doing some active planning around the public safety power shutoff. Tough for me to say. Our concern around fire season. We are in a good place right now, but I've been asking people who are far more competent than me about how we manage these things. And one of the things is that, as I understand it, the power company is still not willing to share where the electrical grid will or will not be shut off. We have an antique electrical grid here in Yakima County. So that's concerning because we don't know the full impact of where people will be in the event of a power shut off, but they're not sharing that. So they said they're going to be willing to have conversations, but I don't think that it will be a local decision.
Yeah, if I could, Mayor Byers and I actually were both at the public forum that Pacific Power had just the other night. And I actually, before that, had an opportunity to sit down with their leadership, including the CEO of Pacific Power, came to our office and visited with the and you're right, we don't have all the answers we need yet, but there were one of the things I thought that was most encouraging was that when we know, of course, they've reduced that footprint of when they do a power shut off, which is something I think a lot of us were pushing hard. That's been reduced from about 16,000 to 600. But one of the things that they introduced was an app. They have a Pacific Power app where you can actually anybody in the public can download that and actually request notification. And so it can. There are times when they could, where they're trying to look at the weather patterns and what's going on and anticipate whether there's going to be fire or where it's going to be fire, that we can get some advance warning sometimes. I mean, they didn't say it's going to be a lot. It could be, maybe 30 minutes or something, but that offers some help to people and businesses. And of course, we did have some industries there, like fruit processors are very concerned about, what happens if we shut the power off right in the middle of a shift when we're, that's tough, that's costly. And they also talked about resources for people that were vulnerable. Maybe they're at home and they need medical devices and what happens when the power goes out. Those are really tough questions. But I thought the app was a good idea, getting that information out to anybody who requests it. So you can go to Pacific Power and look that up. I don't want to sound like an ad for them, but anyway, that's I thought it was, an encouraging conversation that they seem to be willing to engage with us.
They're doing a lot more work too with wildlife mitigation. So birds or other things that hit the line automatically goes off to be able to respond much faster to that, to realize it's not a fire, it's a little incident, and they can take care of that right away. They've also narrowed, I forget what they're called, the SCADA, something like that.
Yeah.
These pieces of equipment that will cut off at a certain point, and they're putting more of those in. They're more sensitive. They'll get more frequent reports. They'll get a more accurate report in terms of where the problem really is. Instead of a larger area, be able to to narrow it down in terms of where they might shut the power off. So they've been working, you know, and I was kind of laughing while I talked to them, but they had to say it was true. Every agency in the valley, you know, I said, I wrote one of those letters, you know, impressing upon you the importance of being more responsive and reactive to what's going on in the wildfire season. And they kind of laughed too, and they said, yes, they've been very busy and they're still working.
Yes. And one of the things that we also have to recognize is that if they're concerned about turning off power because, as you said, about the impact of nature or
Mhm.
where there might be the ability to have what they would refer to as fuel or dry gas and so forth, is that sometimes it's based on the time of the day. So if this happens in the middle of the night, they may have to wait until sunlight to be able to lay eyes on it. So these are some of the complexities. And again, we have wonderful partners in fire service here who are very comfortable with these difficult wildfire issues. And so they are guiding us. But it's going to be an interesting summer, so we want to be prepared for it.
One of the things that I think was of great concern to all of us was, what do we have people at home that are on life-saving, like, you know, death-preventing medical equipment, and how are they notified? So they really worked hard at beefing up their communication directly with customers by mail, by phone, by text, and then trying to identify anyone who has that type of equipment in their home that they can respond to, you know, immediately if they're in one of the areas where the power's turned off. So,
Sure.
and working much more closely with our Office of Emergency Management and our fire departments in terms of those communication lines.
Sure. And Ryan will have more updates on that. So
Yeah.
that's all for me, unless others have questions.
Any other questions? Thank you, Mr. Fusco.
Thank you.
We'll move on to Chief Operating Officer Ryan Ibach.
All right, the first item I have is just an update on the letter that we sent to the governor regarding the impact of lost funding would have on public health in Yakima County. That letter was sent on April 9th.
He responded.
No response. Yep, I'm still waiting. The other item is the Yakima Health District has partnered with the city of Yakima and with the county, in particular the Solid Waste Division, for a community cleanup event in the city of Yakima. That is being held this Saturday, May 3rd. And this, the reason why it was important, the Health District felt it was important because studies do show that cleaner neighborhoods do lead to reduction of substance abuse and safer neighborhoods. And so we're working with the city, we're working with Solid Waste Division, as part of the financial end of it. And so this event is from Nob Hill to Tieton, from 16th to Landon Avenue. So that's the neighborhood that was picked this year. This is the 15th year that the city has done this. So they pick neighborhood to try to clean up. They partner with businesses, for example, Les Schwab picks up tires that are in people's yards and our alleyways and stuff.
I'll be out there. Hope to see you all join me, 9 o'clock Saturday morning.
Perfect. Moving on to emergency preparedness, like we talked about, the Yakima Health District is preparing for wildfire season. Wildfire season leads to power outages. And so we're meeting with, in parts of the meetings with Pacific Power, and then also reviewing our after action reports, making sure that we're ready for power outages, wildfire season, air quality and smoke. And then we've also partnered with the Office of Emergency Management for the county on purchasing a storage container that will be housed at the Office of Emergency Management. And the purpose of this container is to store extreme weather, shelter, equipment, supplies. And so we've moved forward with that. And then finally, our remodel of the Yakima Health District starts on Friday, May 16th, is when the contractors will actually start construction. And that phase one will take about 2.5 months. So it'll be done about beginning of August. And so that affects phase one. Our conference rooms are part of that. And so later in our agenda, we do have a discussion on how the next 3 months meeting will look. And then after phase one, we have phase two, which is more in our employee area. And that is projected to be done the middle of September. Be done with our remodel finally after a couple of years. That's all I have.
Questions from Mr. Ibach?
What's that? Yeah, and actually it's come back under budget and we'll see how it ends up. We did get lucky, the construction, the contractors are also working on a project right next to us for People building. And so they're able to kind of use that site as a staging area
Nice.
for the Acton Health Institute, so it helps save money.
Well, thank you. Good report. Now, next is our financial report from Chase Porter.
Good morning.
Good morning.
I think our, what pages are things start on, 9 or 10? Forgive me. We're on page 9 in our packet. For the month of March, we had a loss of 337,000, bringing the annual loss to 521,000. Not as concerning as we factor in FPHS, we'll get into here in a second. Allocated budget through the month of March for Q1 was 3.3 million. And our actual revenues are coming in closer to 2.5. While our expenditures was approximately about $4 million, and our actuals are coming in at $3 million for the first quarter. Any questions on the summary sheet? All right, moving into the next page, the income statement. We're not generating as much revenue as we would have expected. However, that has a lot to do with foundational public health funding being funded in the prior year, where we recognized that revenue last year, and we're carrying that forward this year. At the end of the income statement, we'll factor that in. Major differences right now is in our enhanced and capital expenditures. As our building gets underway, we'll start seeing a big chunk of those being spent out. Any questions on the first part of that? Next page, please. On this second page, I'd like to highlight the FPHS funding. We have a loss of 521,000 as of the end of March for the calendar year 2025. However, we received funding in 2024 that we can carry over into this current year. So we've carried over approximately $1 million from 2024 into the current year, generating, if we factored that in, that would be about a $500,000 gain. So some weird government accounting for everybody, but I just want to make sure everybody gets the full picture. The reason I do this is that if you were to run a trial balance in Workday right now, our general ledger system for 2025, that would show a $500,000 loss. I would hate for me to call in rich, as we would say, and then somebody else would come in and say, well, your prior finance officer was reporting $500,000 gain, and now I'm showing a $500,000 loss. So I just want to make sure that we are all on the same page with that. Kind of weird, but any questions about that? Okay, moving into our program specific P&L. Clay section is our FPHS, and the reason why there's major deficits is that timing that we were just discussing. No questions, we're into the next page. If not a lot, I'm going to note here, unless there's any specific questions. We start coming into differences in the blue section, which is our environmental health section. Q1 is always very volatile for them. They're got a lot of work, but they're not necessarily getting off to the field that is generating revenue. We do that year over year, every year. Moving to the next page, and that's more of the environmental health. Are there any questions regarding any programs? Okay, seeing none, moving into the last page with the cash flow. Through the month of March, we have $16.2 million in excess funding in cash and cash equivalents. We will continue to see that tick down until June or July, depending on when we receive our next round of funding. Are there any questions? Thank you very much.
Thank you, Mr. Porter. Next, we'll move to our health officer, Dr. Bart.
Since the flu season has officially approached the point that hospitals no longer need to ramp up, I thought I'd do a little review of what's happened this season, which has been complicated by H5N1. There was a presentation on Tuesday for a monthly meeting for providers, and they had a nice summary of H5N1 in the state. And I think one of the things I've been trying to find out, and that whoever put that together found out, I think there's been 11 deaths in the state due to H5N1. When you think about the number of herds, cattle and poultry that have been infected, that's not very much passage. And it might not be deaths, it might be infections.
Yeah, infections.
Infections.
No deaths.
It's not
Yeah.
that.
And no deaths. So the number of infections is nicely low, meaning that this year, whatever the mutations were, it didn't acquire the material to really infect people very efficiently. And I think there's still been no proven human-to-human spread of H5N1. That would allow an epidemic and possibly a pandemic. So just to review what flu is all about, it causes infection in pigs, birds, horses, and humans, and with H5N1 recently, more mammals are on the list. The avian strains that we've dealt with over the last couple decades are all part of a group called influenza A, and that's the epidemic influenza and the one that is seasonal, mostly wintertime. Influenza B is not part of pandemics, and it has a year-long presence. So you don't see a blip in the winter. All the pandemics historically have been caused by strains that have the H1, H2, or H3 protein, or the N1 or N2 protein. So some combination of those. Those two proteins are the ones that allow attachment to cells where the influenza infection can occur. And those proteins mutate over time. So you can get flu again, even if it's with the same strain, H5N1 or H1N2, you can catch it again because it undergoes random mutations similar to COVID. COVID just does it faster. So what happens with these strains where these different combinations of two proteins can occur is the pigs get infected and waterfowl can pick it up from pigs. In the pigs, the strains that become human strains with strains from avian can mix together. So you can get one from column A and one from column B. And then the waterfowl will fly on their regular migratory routes. In the case of influenza, the waterfowl are flying up the east coast of Asia over across to Africa, or rather Alaska, and then down through North America into South America. So the waterfowl are transmitting that, and they are, if you've ever been to a park that has a lot of geese, those geese have pooped all over the place, and in that poop is the flu, and that's how it gets spread further to other animals and humans. So the mixing is one of the reasons we keep seeing stuff coming up every year, and occasionally the mixing results in a strain like H5N1 that humans don't have a lot of experience with. So all of us have had flu in the past. Many of us have been vaccinated multiple times for flu, but H5N1, there's not a lot of pre-existing immunity. Fortunately, it hadn't this year developed the capacity to spread easily into humans and hasn't developed a capacity to spread from human to human. So don't know what will happen next year. That strain could still be around. It could mutate. So, we just have to continue to encourage personal protective devices where at-risk populations are, like nursing homes and hospitals, when the rates in the community are high enough, and encourage vaccination, which doesn't prevent flu, but it prevents you from getting seriously ill and requiring hospitalization. And that's because flu happens quickly after exposure. So the amount of help that your body's able to put forth in that first week of infection is much different than, say, rabies or measles. Rabies or stuff takes longer to develop. If you're vaccinated, there's existing antibodies that can be triggered by infection and still have a big effect, less so in flu than COVID. Last year, I think 70 cases were confirmed in the United States in humans. There may be more since this report came out. Worldwide mortality from infection was 40%. So that's one of the reasons they call it highly pathogenic. But remember, not that many people come down with that. So the total number of deaths isn't that high. And the people who have immune system problems and generally bad health are the ones most at risk, which is true for milder influenza disease also. I want to shift gears now to an interesting article that I read connected with COVID. And this particular article that I read talked about the mandated vaccine program and how that came about. And I think one of the reasons a vaccine mandate came about, because people didn't line up to get vaccinated. There was a lot of information circulating before COVID that was disencouraging vaccination. And then during COVID, with the new technology, which is actually old technology, but it was new to the general public, people were worried that the vaccine might have some side effects. So the mandate emerged from a desire to get more people vaccinated so there'd be less severe disease so the hospitals wouldn't get overwhelmed. And that did happen. The hospitals did get overwhelmed. For those of us that were in the hospital, those of us who had family members or friends that were in the hospital, it really did get overwhelmed. One day, I was talking to one of the nurses, there was 11 helicopter flights from Yakima to various critical care places where there was availability, just to give you an idea how bad it was. So the mandate came out of that. Now, there's one thing beyond the mandate, and that's compulsory. And we haven't had to have that for a vaccine except in Philadelphia in 1991. There were so many cases of measles that occurred in two populations that had reasons, they had reasons they didn't want to get vaccinated. So once it got into those populations, it spread, and Philadelphia mandated vaccination for all people that hadn't had measles vaccine. The epidemic ended, but the person who was giving this presentation thought that the season for measles, which is a winter disease, had ended, and then the combination of the vaccination and maybe more predominantly the change in the season eventually eliminated that particular epidemic. There were over 1,000 cases just in Philadelphia. Texas and the other outbreaks going now are probably on rate if they continue, which I hope they don't, to surpass that. But, you know, to have one geographic location with so many cases was pretty scary. For those of us who are approaching that certain age, if you received zoster vaccine, there is a chance, in a study of over 100,000 patients, there is a reduction in the incidence of dementia, which if you already have dementia when you're vaccinated, won't be different. But like many things in medicine, when you look at the data, sometimes it's less impressive. It might be statistically significant. And over, say, a whole country, it can make a big difference, but in a community, not so much. So the vaccinated individuals had a 2% lower chance of dementia. So for us sitting around the table, it might not make much difference. When you look at that nationwide, that was an interesting correlation. All right, so we're still having issues with TB. Over the last 30 years, there's been an overall decline in the number of cases of tuberculosis. But since 2020, cases have increased, predominantly among sub-Saharan Africa and Southeast Asia. And now with the regression of COVID deaths, TB now worldwide is the most common cause of death. And the disease is much worse in poorly resourced countries that I just mentioned. And one of the ways to combat this is to supply treatment to the people who become infected, because it's not hard to diagnose at all. One of the main programs that supplied money to provide treatment is USAID, which has been eliminated. So the amount of drug available in these high-risk areas of the world is going to be curtailed significantly because of lack of money. The important thing to know about this is the cases are treatable, and if the drugs are made available, you could greatly decrease the number of cases. So this may lead to increased cases in the United States and other industrialized countries, because as one of my former mentors stated, which Andre knows well, Bill Schaffner, TB doesn't need a passport. One of the other things that's contributing to increased TB is the number of conflicts that are going on in the world right now. And public health services are disrupted in areas of conflict. So it's hard to get people the services they need to test, diagnose, and treat TB. So that's going to contribute, and probably has contributed, to increasing rates of tuberculosis worldwide. Those conflicts create increased numbers of people becoming refugees and then migrating into the areas where the refugees can be escape from the conflict that they're involved in, and the diseases travel with that population as well. So with all these things going on at the same time, there's an increased risk of TB occurring in areas where it was previously controlled. One of the things that public health service, and not the formal public health service, but public health services provide is adherence to treatment. Because the treatment can go for as long as 9 months, you need an infrastructure to help people take their medications regularly. If they stop prematurely, the disease is not eradicated and more spread can occur. If they take it in suboptimal ways, they miss a lot of doses, then resistant TB can emerge, which is much harder to treat and has a much worse outcome. So one of the things that our TB people do is when there is an outbreak and identified active case, they interview all those patients who have active TB to find out exposures. Those exposures are then tested to see if they have been acquired an infection that is not yet symptomatic, and they're treated with anti-tuberculosis medications, and the rate of conversion to active tuberculosis goes way down once they're treated for latent tuberculosis. So that's important. That public health infrastructure is important in tracking and preventing further outbreaks. One of the things that a lot of people don't understand about TB is it takes prolonged exposure. So when we do contact tracing, we also try and determine what the risk of exposure is. For instance, people living in the same household will definitely have increased risk. Or people that work in a nursing home that have TB, they're going to be in that nursing home every day until they're diagnosed, and they're taken out of the employment pool until they receive significant or sufficient treatment.
You know, in those facilities, are staff tested on a regular basis?
Yeah, it depends on the rate of TB in the community. So right now we have an increased rate, so testing will be implemented. And there's also, for instance, a risk assessment in addition to identifying people that have exposures. There's a risk assessment that's done and to not have everybody tested. For instance, the farm workers, I had to fill out a risk assessment to determine, like, for instance, one risk would be that I've taken care of a TB patient. So based on that risk assessment, people are tested to keep the total number of tested people down. If it raises to a high enough rate, then healthcare workers would be tested on a regular basis. It used to be yearly. Then they showed that when the rates are below a certain amount in the community, the risks of healthcare workers getting TB and then potentially infecting other patients wasn't like doing. But with increased rates, I don't know if they're doing full-scale screening at healthcare facilities now or not, because I haven't
It
received.
depends on the risk assessment. I know here because we manage active TB cases, so we test our employees yearly. And then, so like in a hospital setting, most of the staff are screened yearly, and then you can also, anyone who would be exposed, you're also gonna do symptom monitoring. So anyone who develops any symptoms, you're gonna have a protocol to start testing them for TB as well.
So let's hope we keep our public health infrastructure for TB intact. At least in the US, it's not going to be intact in areas of conflict and areas where socioeconomic situations are difficult. That's all I got. Happy to entertain questions.
What about schools and daycare, Dr. Park? Do they get annual testing?
Most might know that.
I think they're supposed to get baseline,
Right.
but I don't,
Right,
it's
yeah.
all based on so they changed it several years ago where you, like in hospitals, it was just routine. Every year you got your TB screening or your testing done. And they changed it more like what Dr. Barr was saying, like more of a risk assessment. So it's based on what's happening in the community, what kind of clients your facility deals with. And so every facility is kind of different.
Yeah, so interestingly, when Multicare took over Memorial, everybody became a new employee. So we all had to get TB tests. Even though I've had them in the past multiple times for other employers, they didn't really care. If they wanted everybody clean in the Multicare system, which is fine. It's no big deal to people blood drawn for the test.
I have a question, Dr. Barg. I want to kind of go back to the vaccination. You mentioned compulsory and mandate. Is there a difference between?
Yeah. If it's compulsory and you don't get vaccinated, then you get into trouble. I don't know what they did in Philadelphia when that happened. I don't know.
Legal trouble?
Yeah, legal trouble. Right. Mandate, you just, the trouble you create when there's a mandate and you don't get vaccinated is other people can become infected. So that's the difference of, let's say, tetanus. You got a tetanus vaccine and you develop tetanus, nobody else can get a tetanus from you. It's not contagious. But when you have a vaccine for contagious illness, and you don't get vaccinated and come down with that illness, whether mild or severe, other people that you come in contact with can get infected. So I remember a couple years ago, I forget Nyla's last name, but she said, I don't think it was caught by everybody. She said it shows respect for other people when you get vaccinated for a contagious disease. I have not forgotten that. Any other questions?
Thank you, Dr. Barg. We will move on to a disease control with Melissa Secretary.
Follow up a little bit on the TB and what's happening here locally. We do have currently 17 cases of active TB that we're monitoring. We did have 2 people that just recently completed their treatment. It's been in social media and the news a lot lately since our last board meeting. So I just wanted to explain that these 17 cases have not happened, like say, over the last 2 weeks because the treatment, like Dr. Barg said, can go, 6, 9, up to 12 months. It overlaps. So some of these patients have been on treatment for an extended period. So we are starting to see a little bit of a slower trend in how many new cases are happening. We do have the outbreak that's happening within our tribal population that is specific. We've been able to actually see the genome sequencing, be able to say that, yes, these are identical strains. And then we also, on the other side, have an increase just in a TB overall in the general community. But I want to make sure people are aware that, as Dr. Barg said, you have to have a very prolonged exposure to actually get TB. You're not likely to get it from going to a grocery store, going to a casino, going to a social event, a basketball game. You're not likely going to get TB from that. We're talking about a very prolonged exposure, household contacts, maybe somebody that you work with in a closed environment day in and day out when they're very infectious. And just because somebody has active TB doesn't mean that they are infectious to other people. There's a lot of different variants. So I just want people to be aware that when you're looking at like TB versus measles, highly contagious. You're likely going to get it if you're around somebody, even for a short amount of time, versus TB is very, it takes a very long, prolonged exposure. So I just wanted to clarify that for the community. And then pertussis cases, we're still seeing an increase in pertussis. We've had the outbreak going since last fall, actually almost a year now. I expect that with the population that we're seeing it in here locally is mostly in school-aged group. So I would expect that with indoor sporting events finishing up and schools transitioning to summer, I'm hoping that we'll see a decrease in our pertussis cases over the next 2 months, hopefully. And then I just wanted to give an update on our overdose fatality review. We just had our first quarterly meeting of the year. It was our very first meeting. We just started this program. This program, like I mentioned earlier, kind of looks at the lifespan of the individual and how we can look at things upstream to prevent from the addiction even happening. And so this first one, we were just kind of getting our bearings and everybody becoming familiar. This brings in stakeholders from the community, law enforcement, people with lived experience, emergency room, CPS, like a large group of stakeholders. The coroner's office was there. And one of the things, just low hanging fruit, one of the things that just immediately we thought of was for an individual who is seeking treatment, one of their barriers to housing is they need to have an identification and they need to have insurance to be able to get treatment, right? So housing barrier is not having identification and then not having insurance to be able to get treatment. And so the state provides $5 vouchers, but it's about $30 to get your identification. So there's this barrier, even if somebody is able to get into housing, have a housing available, there's these barriers that I think are low hanging fruit that the committee looked at on ways to maybe we can problem solve that in the future to help individuals. Anybody?
If I may, I wanted to share with the board a compliment to Melissa and the staff. I'm really in their debt. It's exceedingly complex to have, and with TV, to have multiple cases that may be a cluster. To also manage TV patients and then also provide partnership and support to the Indian Health Service at the very same time. So those are three different distinct missions within this TB process. And so I share that with you because this is exceedingly complex. It's something that the state's aware of. Other people call me daily to ask how we're doing it because, again, that's one of the reasons I want to pay my compliments both to the staff and to the board for understanding years ago why we cross-train and why we invest so heavily so that we have staff that are prepared for these kinds of events. Because there are other counties in this state that don't typically have TB patients, and they are absolutely unprepared for this kind of circumstance. It's a tremendous amount of work. Melissa and the team make it sound easy, but it's actually exceedingly complex. So I just wanted to share with you that behind the scenes, there's a lot going on, and that's in full partnership, obviously, with both of our doctors who are working with us, but also with an incredible amount of communication within the county with providers and so forth. So thank you.
Yeah, we also added on our partnership with, as we know, Catherine is Sluskin from our board is also involved with the tribal public health. And they've just recently brought on a couple of physicians as consultants or per diem physicians that are able to help us with the current outbreak situation that's going on. So it's been a great partnership to be able to have them as resources in addition to the Indian Health Services. It's a great partnership between all three of our users.
Any other questions or comments?
Just a quick question, when you talk about working with Indian Health Services, it sounds like we have a good relationship right now. Has that been the case in years past, or is it?
Not necessarily.
We've gotten
No,
better?
It's gotten much better.
Great.
A lot of it is just being a resource, just letting them know that we're here to help. And I think that Andre always says we're the doers, or, we always want to help. So I think that's known throughout the community that we're here to help.
Thanks.
We've always
Okay.
had a good line staff.
No, I was just gonna say that, I think it was 2 years ago, the state, was membership difference at the state level, and then required every local board of health then to find a tribal representative in their area. And it took a while to set that up, but I think it's very productive.
Yeah, it's so that there is a difference. You have us as local public health, then you have Indian Health Services, who is still run by your federal government. And then you have the tribal public health, which is tribal members that are running that. So you really need the combination of all three, because sometimes there's just a trust issue or a preference on care. And so having the combination of all three agencies has been really impactful.
Yeah, and the relationship with tribal health has really, I think, progressed dramatically and certainly with Catherine's leadership. Not every member of the enrolled tribe wants to be seen through Indian Health Service. And so that's a complexity. Also, Sovereignty is something that's top of mind always, but every member who is enrolled with the tribe is also a member of our community. So we want to extend our service to them and provide resources. And so that's actually been a wonderful working relationship for us. We had a responsibility to invest in that trust bond, and that's worked out well. But it is a long-term process, and we invest a lot of time in it.
Just a quick question, knowing that the disease burden is higher in the native populations and knowing that the state is picking up the cost of the drugs for the patients, is there any funds that we get from the IHS or that IHS specifically puts toward TB care because their burden is higher?
I don't know where they're, I'm assuming that they're funding, I would assume, I don't know, you know, where IHS's funding comes from.
IHS is federal.
Right.
And so, the state does provide money to Indian Health Services through the Foundational Public Health Services. Again, it's usually, nations are normally their governmental partner is the federal government.
Right.
So we don't receive any additional money. We do receive support from the county. It's a mandate, through the legislature that TB is a local responsibility. So
I think that would be an interesting thing for potentially our board to write and just bring attention to the idea that the federal government could play a role in helping fund these local problems because they play this special role in funding the IHS. And so potentially we can bring attention to something that's probably not well understood, different funding sources pay for different things. And maybe if we bring that to people's attention, it might get a few extra dollars. I don't know, it might not, but I think it's at least worthwhile to entertain that option.
that's actually a great point. I won't be able to do justice to it, but I think either of you doctors or Melissa could explain that in the lower valley, we do have this recurring clustering effect. I don't know how to explain that the DNA, you know, actually some of the testing shows that we are sort of having a recurrence.
Yeah, so when they look at the DNA, then just basically, they can look at it and see that we have 5 cases that are genetically linked, that we know that these 5 cases are connected to each other.
Same organism, possible same source.
Yes.
Right.
Yes.
And, you know, and that also has to do with living conditions.
Sure.
That has to do with poverty, that has to do with cultural choices that people make. So it's complex to say the least. And that's one of the reasons, actually, I'm glad you brought that up. It's not just a funding issue, it's a recognition that in rural communities, we have specific types of needs and occurrences that don't often happen elsewhere. So I think that's a great point. I'm always surprised, in fairness, that we have so many guest workers from other countries here, that we don't have more TB from that. That was an amazing surprise to me, because in other states, that's certainly an issue. Having said that, this issue of people being impacted and not having options is difficult, especially in hardworking, modest communities where people, when we say you have to isolate, you have to not go to work, that's asking a tremendous amount for people who may not have assets or banked leave. So those are all impacts, and I'm glad you brought that up.
Well, I think if you look, Andre, at the Dr. Bart's comments on the continued and continuous exposure, our population of imported workers are mostly outdoors, mostly transiently moving around, and so the exposure patterns are probably not enough to get people close enough. They also work at distance from each other, so the exposure patterns are probably maybe not the best for transmission in that environment. So nonetheless, if you look in warehouses, you might see it. I don't know, where it's a little more closed.
Sorting line.
Yeah, sorting lines, right. So if you have closed spaces, that'd be different. So, but it's interesting, and probably also it has to do with, as Dr. Bark mentioned, screening. I'm not positive all the screening that takes place in these institutions on the bring-in workers that come in under the visa programs. But I know that they get a initial screening at least. I don't know how often it's repeated, if it's on every entry or not.
I can tell you that the health district, part of our responsibility is just to work individuals up who come in for permanent So immigration, refugees, they actually come through and if they're screened and found to have positive quantiferon, which is a positive TB test. Then we get notified here at the health district and we work every one of those individuals up to rule out active TB and then treat them for latent TB if we need to.
What about the
But
seasonal
The
ones?
seasonal workers, I am not aware of any type of
Right.
screening that's happening.
So the numbers might be higher than you think, or just the exposure's not great enough, so.
We found historically that, if I understand it correctly, the medical care for a seasonal worker is the responsibility of the company that sponsors it.
Mhm.
We have found that there have been circumstances where that was lacking. And in fact, the health district has, again, under Melissa's leadership, worked to pay for emergency vaccinations for people when we had issues that were outbreak. And also, frankly, it's not easy to say to a clinic, well, now we have 200 people who need you to come in immediately to do something. It's not an easy process. But again, from an emergency preparedness standpoint, this is something that we haven't visited recently. So we're going back years now. So that's actually a great point for us to work on as well. How do we prepare for a situation where, frankly, we're talking about the concern for the community and the spread of a disease, and we can't be sitting around asking whether someone's going to pay for XYZ vaccination. What we need to do is to ensure that the safety of our community, which is why we paid for those vaccinations years ago, but we should have a plan for that. So thank you.
Anything else? And not, thank you, Melissa. We will move on to environmental health with Sean McGee.
All right, good morning, everybody. So we've been really busy in environmental health. It's, as you know, coming into our busiest time of year. In addition to that, we have the new septic regulations that were implemented, took effect from April 1st. So there was a lot of learning done by staff in preparation for that, and a lot of teaching happening to our industry professionals to get more familiar with the WACs, or the new WAC. More specifically, right now, we're looking at minimum lot size requirements, different soil typing means different treatment levels for wastewater treatment disposal. So getting more familiar with that has taken some time, but it's been a smooth implementation and haven't hit any huge barriers with our industry professionals so far. So it's going well.
The April 1st wasn't jinxed after all.
No, it wasn't. That was not an April Fool's joke. It was very real.
We have 3 things. for April 1st.
Don't say it out loud.
We haven't gotten all 3 yet, so.
In addition, last year we had an environmental health intern through University of Washington's summer internship program. We're gonna have another one this year. So Sophia will be joining us from middle of June to middle of September. This year she'll be helping us out with our West Nile virus surveillance program, some mosquito trapping, and our harmful algal bloom sampling in bodies of water that people frequent often to recreate in. So we're glad to have Sophia come on board and help us out. Now for some of the more bigger updates. We've been dealing with an issue within the city of Yakima that's been pretty persistent over the last several weeks in relation to illegal food vending. We were getting complaints from some of our permitted mobile food trucks that operate around town that there was pop-up taco stands happening throughout the city. We responded, we went out and made contact with those vendors. We found that they were not permitted in any way. And they didn't really react too kindly to our which started as education outreach, trying to help them get permitted. Now it's to the point where we have no choice but to close them down when we find them. We close them down and they're back again the next night, sometimes in the same spot. So it's pretty egregious at this point. We're partnered with the city of Yakima, code compliance and YPD to figure out the best way to approach this moving forward and how to address this issue. We believe it potentially could be a increasing issue across the county. So we're trying to build this process and the system that we can share with other cities around the county to, hopefully prevent illegal food vending, which, is not only illegal, but it does, carry an, imminent health risk to the public. We see a lot of increased risk for foodborne illness due to lack of, sanitary control.
We obviously aren't getting food handling cards or anything like that, so.
No, and the vendors we've made contact with, there's no hand washing. There's no temperature control, no coolers with ice, no refrigeration, no inadequate hot holding of cooked foods. So it's pretty they wouldn't qualify for a permit the way they're operating now anyway. So yeah, we're putting our best foot forward to try to curb that issue and guide them to getting permitted. But at this point, there's several vendors that have just continued to operate without permit. So our goal is to just get that stopped and promote the right way to do it. And the reason we've involved YPD is a couple groups, and I should say that we think this is kind of being organized behind the scenes. We believe there's kind of a group of individuals, and they're sending out multiple taco vendors across the city. They all have the identical setup, serving identical food products. Just different people running different pop-up stands. So there's a couple groups out there that get a little aggressive in nature when we show up. So we call the Yakima Police Department to just be there with us while we go through our process. So it's many late nights for some of us, and I just want to say thank you to the city of Yakima for their support and figuring out a solution in the future.
I had a friend who recently had an experience at a potluck meal. And everybody came down with norovirus. Not good, everybody at the party, except for the person who brought the sliced melon, who had worked with their baby and then sliced the melon, and so that's how quickly it happens. And how, so my concern is, are we letting the public know so that they're aware they're not going to these stands?
It's well, we do let them know, like customers that are there and they ask why, we explain it to them, but they end up still not being happy with us. These vendors have a large following on social media, and a lot of them, there's the ones that aren't impressed with the food or recognize that they're not doing it the right way, but there's a lot that also have not the greatest opinions of us showing up and closing down. So it's something we're discussing and how the best way to approach that community outreach around this issue would be. But there's a lot of layers to it. It has to be tactful and how to best explain that and not come across like we're just, attacking somebody trying to make money. And explain that there's a process and how to do it right.
I wanted to pay compliments to the team. It's not only nights and weekends, but also the relationship with the city has been excellent. We've had great support from the city manager, Vicki Baker, certainly our mayor on our board, thank you, Mayor Byers, Sarah Watkins, lead attorney, Captain Janice. Certainly a slew of officers have been very welcoming. It's been a great deal of work, but it's not just a health concern. It's the fact that these people are operating private property. They're not allowed to operate. They don't have a permit with the city. They're not code compliant. They're certainly not here to invest in quality services or quality equipment. This is a make money and move on attitude. The reason I share this with you is it's a complexity that we haven't seen here. We have a vast majority of those providing services here are not only compliant, but they're willing to engage in a great relationship because they care for their patrons, and they don't want anyone to get sick, and they want the quality of food to be high. And so we've always been And so for all the things that people may say about Yakima, we don't see this as an issue. We don't have this type of illegal treatment. But it's not just on our city streets, it's also bending to those who are working in the field. So we want to make sure that we address this quickly and well. But there's also some legality to what you can, who can do charges and how that can be managed and what would lead to an incarceration. It's pretty complex. The reason we want to do this now is we don't anticipate this stopping. So we want to address this. And again, I'm glad that it's happening. Sorry, but I'm glad it's happening in a large city like Yakima that has resources. If it was happening in one of our smaller cities, I don't think it would be able to be addressed as quickly. So we'll work on this and then work in partnership with the other cities, as Sean said.
The final thing is, I cannot remember if at the last board meeting, we discussed the PCHB decision around Kate. But I did want to mention that, we did get the decision from the Pollution Control Hearings Board. And that decision was to uphold the denial of the permit, that the health district did, back in July of 2023. And moving forward, the Kate and LPL needs to come into compliance with state regulations, state, local, and federal regulations before a permit can be issued. So at this point, we've communicated to them that they need to get into compliance with their Yakima County conditional use permit and their Yakima Regional Clean Air Agency air permit before we can consider an application for review. So that's where we're at with that. We're in a bit of a holding pattern, waiting to see what work can be done between the Kate landfill and the other two regulatory agencies that have permits with that business.
So Sean, in light of that PCBH, thank you. I didn't think that was right. PCHB, there you go.
You almost got it.
Many acronyms. Ruling, Caitlin announced that they were shutting down temporarily. Have they actually shut down?
Yes, they have. We responded to a complaint for smoke out there, which we didn't see any when our staff went out there, but their gate was shut. So we do believe that they have shut down, and what was communicated to us is that they were closing down voluntarily under the advisement of their legal counsel. So they still have a deadline that they can appeal. Yeah. They still have a deadline that they can appeal to Superior Court but I don't believe that would involve us as much. What they can appeal to is the actual decision made by the Pollution Control Hearings Board, which would involve just looking at the transcripts of testimony, the decision itself, and exhibits that were submitted during that hearing. So to really ensure that they were given due process and that was all followed. We believe it was. Yeah, it was a good outcome for us. Yeah.
Sean, I just want to make mention what a wonderful resource it is. You mentioned the intern coming from the University of Washington and the fact that they get an opportunity to intern with the Yakima Health District. I think we should always recognize that these students that come through and young new professionals are our best asset toward gaining new employees down the road. And so just recognizing the fact that it's a wonderful opportunity, not only for the individual student that can have exposure to the professionals here, but also for the institutions that they go back to and talk to their friends, colleagues, et cetera. You probably get a number of applicants, I would imagine, because of that. And so I think it's always important to recognize the importance of our schools and the role that they play in feeding us new employees down the road, and other counties for that matter.
Right.
Yeah, the intern last year had such a good experience, and when she reported back to University of Washington's environmental health program, they were eager to reach out to us about this year as well. So it's been really great and a great resource for not only University of Washington but for us too, because it's an additional person that we have to do some work for us, but also learn and grow the profession. Environmental health is pretty specific and, you know, not a lot is known about it unless you kind of go into the public health field and find it interesting.
Well, Dr. Atterbury, if I can share how exceedingly proud I am of our environmental health program. We had to recognize that there's been a generational shift in terms of people coming into public service. We can't expect people to have the forethought to be in public service for an entire career. And so what we find was, it was vexing that we had people who were coming in and transitioning out more quickly than we had anticipated. Ryan and Sean and the entire environmental health is a template for how we can quickly train up staff, get them in the field, give them incredible support with cross training. But the other thing is that we turned our own personal attitude change, and myself included. Rather than thinking, oh, we've just invested all this time in someone and now they're leaving, those people, if they leave with a positive experience, have a positive recognition of what we do here. So there are people in our community now who understand our role and how vital it is. And I'm really encouraged how many of our staff, not just in environmental health, share job opportunities with their friends and their colleagues. So there are multiple people that we've met who actually were encouraged to come work here because of people who are working here. And these are not people who are thinking about the pension or the benefits. They like the culture here, they like the work. And I just wanted to share with you how many people we meet who want to do right by our community. And so they find that they can do so here. And I'm grateful you bring that up because it's internships, but also it's because of the internal reorganization that really Ryan spearheaded.
Thank you.
That's all for me.
Oh, thank you. Any other questions or comments, Ryan? Thank you then. We'll move on to public health partnerships with Lily and Bravo.
Thank you. So my first update, as a reminder, part of our foundational public health services money included some money specifically earmarked for opioid use prevention efforts. And that's what I'll be speaking to first. So one of the strategies, as you've heard us use that for that opioid use prevention specifically, is not to look at just the use, but rather what's contributing to that use. So looking more at some of the behavioral factors and the community resiliency piece. Last year, we worked with the community coalitions to support the work that was already happening, but this year, as a reminder, we've chosen to work with NAMI, which is the National Association for Mental Illness. And NAMI has been working with the health district to provide several different curriculums into the community. I'll list them off and go into a little bit of detail. It's Ending the Silence, Compartiendo Esperanza, which translates into providing hope or sharing hope, and then also the Trusted Adult Toolkit. So earlier this year, I did mention the different these same workshops were provided in English. That was in January and February. And then this month, in the month of April, they were provided in Spanish. So that's the over the last month in April specifically, there have been over 100 people that have attended those 3 workshops. The 3 workshops cover topics such as helping parents initiate conversations with their youth and family members, mental health, adolescent brain development, as well as addressing youth mental health concerns. And from these 3 workshops, we were able to partner with, again, NAMI to provide these services to families from Eisenhower High School, Washington Middle School, and working with La Casa Hogar, which is a community-based organization that provides services to Spanish-speaking families. Moving forward, in the next couple of months, we'll be hosting another 3 workshops specifically with La Casa Hogar, and we'll also be expanding to work with Yakima Neighborhood Health Services, the Youth at the Space, the Yakima Nation Youth Tribal Council, and then other youth-serving agencies. So again, wanting to make sure that we can reach as many families as possible to promote being more comfortable talking to their youth and really understanding what the youth are experiencing. That way they can have a better home life, which hopefully builds the resilience to preventing the use of drugs in general and other bad behavior, negative behaviors, excuse me. Any questions on that? Thank you. The next update I will share is related to community gardens. So here at the Health District, we have something called the Supplemental Nutrition Assistance Program. And through that program, we were able to work with 3 different community garden sites. The first being Yakima Housing Authority, which has 2 sites, Chuck Austin Place and Valley Square. Our staff member there is helping them to create a co-op gardening model with the residents, which is again going to promote access to fresh produce, and then we'll also include nutrition and gardening workshops. The other site is at Wapato Community Garden, which we have referenced previously. That was primarily supported by the school. And at that particular site, we have hands-on learning and leadership classes, and then as well just learning more about the agriculture of the area in general. We're also working with Salvation Army and OIC to help the integration of hydroponics for their community gardens, the nutrition education, and also establishing some cooking programs there. So the project aims to build not just access to food, but those long-term skills for food availability, also building confidence, and ultimately, hopefully reducing reliance on food assistance programs overall, which we know, given the current state of affairs, that's going to be important moving forward. On to some bad news. We did receive notice from the EPA that the $1 million grant that the Washington State Department of Health received for the environmental justice work that was taking place in the Lower Valley, and that title being the groundwater work that we were wanting to address with community health workers, that funding has been cut. We were told to stop work on that as of April 3rd, 2025. Again, that grant was received by the Washington State Department of Health, but the funding was primarily provided to the Yakima Health District and our partners, that being Heritage University, Central Washington University, and the Northwest Community Education Center. And again, the reminder there being that we were going to focus on well water safety and air quality awareness in the Lower Valley specifically. But unfortunately, we aren't able to move forward with that work, but we were able to do most of the planning. So we are ready to go and implement that work in a different manner once we identify some resources to do so. Any questions on that piece? And then just as a follow-up, last month I mentioned that Commissioner McKinney and Alicia Strami were invited to the Yakima Neighborhood Health Services to learn more about the youth campaign that was taking place. The meeting did take place. Alicia was able to share some helpful insights in terms of how we can utilize positive norm messaging in the future. So just a last meeting, so I wanted to make sure that that was brought back to the board. And then again, the youth campaign has been launched as of last month. That was the same campaign that we did last year, but just expanding it into different avenues. The youth campaign being, they developed some artwork about what preventing drug use meant to them. The different art pieces were now utilized for a broader campaign with social media, billboards, radio ads, and things like that. In addition, we are getting ready to launch the caregiver campaign, which is for adults to look at each other as a resource in terms of knowing that the conversations that they have with their children or their little siblings or just other youth that they come in contact with are difficult, and looking to their community, being other parents, other teachers, or other caregivers to lean on and connect with to help facilitate those conversations as well. And then the last update I'll give is around firearm safety events. On April 27th, the Health District helped Safe Yakima Valley's Shreds and Meds event in Grandview. We were able to provide them 100 lock boxes, trigger locks, and cable locks, that being 300 items total. And they were able to provide those to the community with the help of Grandview Police Department. And then up in, This week, we'll be helping the Sunnyside Youth Coalition with another 100 cable locks to provide it within their community as well.
So, Lillian, does the Health District do any work with Northwest Harvest?
Not currently.
Okay, so yesterday they had their 2-year anniversary for their major center here in Yakima. And Andre, you may remember this, but in 2020, when COVID came,
Yes.
they actually were active here in Yakima to a degree, but their main headquarters was in Tacoma.
Right.
But they started communicating with the elected officials and leaders in Yakima because it was one of the largest counties, one of the second most impoverished, high level of essential workers. So they started to look at us in a different way in terms of resourcing the state, and they moved their main operation right here into Yakima to that wonderful Northwest Harvest Center, food distribution center and market on, and what's on the market's on one side and the distribution is on J Street. So it was good to be there and to see what they're doing, how they're continuing their great work throughout the community in a lot of ways. They have a social media campaign they've been doing also where This year, the theme is, the meaning of food. And so every month has a different, and it's like the month of April, the meaning was, health. How does food relate to health? And coming up into May, it's culture. How does food relate to your culture? And they're doing educational pieces all the time as well. So it may be an opportunity for some unique educational pieces or something in the future, through the health district.
Yes, absolutely. And that's actually where with the community gardens, especially with the food distribution, I do see a connection
Yeah.
moving forward. And I know Thomas Reynolds, the executive director, was interested in having that conversation once we had a little bit more experience with this moving forward.
Right.
So I completely agree.
Well, I'm really grateful you bring that up, Mayor Byers, because years ago, one of our plans was also to address some of the realities where food, security, accessibility, and also cultural influences impact. And one of the things we talked about was cooking demonstrations and so forth. So we have people who have traditional cooking. I think if you ask certain older people in our community, they would say, you need to use this particular ingredient. This is how it's done. This is what makes it taste great. That doesn't necessarily translate to the healthiest option, probably putting it mildly, but coming up with options for people and also being able to make great food with local resources.
Yes.
We found, it was a surprise to me when I moved here that given the fact that we're the fruit and vegetable basket of the nation, that there are a lot of people who do not cook with fresh fruits and vegetables. A lot of people, like many people who are busy and have families and work a lot, prepackaged foods, even if it's fruit and vegetables, is something people rely on. So that's a more expensive option. So we wanted to address the fact that there are ways that you can prep food and make great food, but again, we got off track. So I'm glad you brought that up. These are the things, and I'm going to ask and encourage, please, for the board to mention these things to us because these are great initiatives. Thank you.
Anything else, Lillian?
I have one more, just, since we're on the topic of food, I forgot to mention, my update, I believe this weekend is our temporary food event workshop at Cafe 1990. Next week, sorry, at Cafe 1997. Much like last spring when we did that, it is an invitation to current food vendors or people looking to become, break into the industry on how to set up a proper temporary food event stand. All the things that they need to do to operate safely. How do they go through the permitting process? Really, the goal is to break down the barriers of any fear or apprehension people might have and coming to the health district and going through our process. We're trying to make it as simplified for them as possible, give them the tools and education needed to make sure that once they do get a permit and they're at their event, that they're confident that they're doing it the right way and serving some.
But again, establishing that relationship
Mhm.
with you as a partner rather than as an obstacle. So,
Right.
Yeah.
That's the goal.
Good.
I just want to quickly add, the reason that it's being hosted at Cafe 1997 is actually because it was the idea of the owners to help host this and help bridge that gap, which is something that we're very grateful for. So I did want to recognize that.
Anything else for Lillian this morning? Thank you. We'll move on to community programs and Gabby Alvarez.
Hi, good morning, everyone. So I wanted to start off mentioning as part of our developmental disabilities transition program, we offer Job Foundations, and Job Foundations is a career readiness initiative that helps the high school students identify their individual skill sets and prepare them for future employment opportunities. So as the end of the school year is coming up, we have graded 12 student Job Foundation reports, and we have 8 students already signed up for next year. I wanted to mention that from previous years, we have grown the amount of students by 70%. This has a lot to do with the work that our transition specialist has been doing. So kudos to him. It's our numbers have been growing a lot throughout the years, and we expect them to grow more. Like I mentioned, this program is in multiple school districts. Yakima School District, Granger, Zillah, Wapatosila are some of the school districts we are working with, and giving students a head start in preparing for employment and career opportunities. Any questions on that? Moving on to breast and cervical health program. So we have collaborated with the Yakima Valley Farm Workers Clinic through our partnership to gain direct access to patient information via Epic while remaining compliant with HIPAA guidelines. This improvement is going to enhance our ability to identify and verify program eligibility quickly and streamline our communication process since we are contracted with more than a dozen clinics for farm workers. So we believe this will reduce delays in accessing patient information and it'll strengthen our collaboration with healthcare providers. Any questions on that update?
So you mentioned farm workers. I'm assuming you're still doing it with other entities like Sunnyside Hospital, that.
Oh, yeah, we have multiple, but this one is just strictly with farm workers because they're allowing us to view patient information with them since we are contracted with them and we have so many clinics that we work with throughout the valley.
We'll have access into the EMR system.
Okay.
So instead of requesting records, we have instant access.
Okay.
Makes it much more efficient for the staff to do their job.
All right.
Yeah. And for front desk, we have officially we filled our position for Gloria Castaneda. She will start on May 12th. We did lose a front desk employee, so we are filling that position next month. And that is all I have for you today.
Any other questions for Gabby? All right, thank you. That's the end of our agency reports. We have no unfinished business this month. We do have new business, the Board of Health alternative meeting locations during the Yakima Health District office remodel.
Okay, so as I mentioned earlier, that we'll be starting our remodel of the health district in about 2 weeks. And so this conference room will not be available for May, June, July meetings. And so we have identified about 5 different locations we can have it at. So if the board or the other option would be doing it like through a Zoom meeting. So if we'd like to do it in person, we can start exploring which location would be the best facilities and let the board know if that's the direction we'll go.
Preferences? I'll just be honest, my preference is personal. I got so tired of Zoom meetings during COVID that I like the relationship. So that would be my preference, but it's a board decision.
Do we get to vote on the 5 choices or?
What we were gonna do is just go around to the different locations. I think one of them we probably kind of ruled out because it's not conducive to the size. And so really, we probably have 4. And so what we do is just look at the facilities and availability. And then we would just let you know where it's at.
Any other input from board members on preference of Zoom or personal meet?
I can do either.
Either. Well, let's look at the sites.
Okay.
You tell me what the sites are, you're gonna look first.
So a couple options were City Yakima, City Union Gap, Department of Ecology, Comprehensive, and
Courthouse.
the Yakima, or the county commissioners have the courthouse. That one is set up for 3, like a 3-person board, so I don't know if that one is big enough. So those are kind of 5 locations that we've identified.
The room's big enough, but we don't have many tables. It's just, yeah.
Well, Department of Ecology being across the street, is easy for everyone. So if your car drives to the place you normally go, then you're just across.
You can walk across.
You can walk across the street.
So yeah, so probably Department of Ecology is we'll be talking to them with the facilities first, and if we can do it there, that's probably the most ideal.
If that's a conference room, that's a nice setup, actually. Yeah.
Yeah, they have streaming capabilities and plenty of tables.
Okay, we'll move forward with that then, and we'll let everyone know once we find out.
Thank you.
Great, thank you.
That brings us to the end of our meetings. I would entertain a motion to adjourn. Okay. Yes, we have motion and a second to adjourn to our next Board of Health meeting of May the 20th. Location will be announced. TBA. All those in favor, please say aye. Aye. Any opposed? Then we are adjourned. Thank you very much.